So now we'll shift focus and talk about your mealtime prandial insulins. And so these are going to be there's two different classes, one known as the rapid-acting insulin analogs and then your short-acting insulin. And these are going to provide you your mealtime coverage as well as be the insulins that patients use to provide themselves correction doses. And again, correction doses is going to be the amount of insulin that a patient needs to take to bring their blood sugar down to goal. So regular insulin has been one of the insulins that's been around the longest, and historically it was used multiple times a day, frequently 8, 10, 12 times a day 100 years ago to control blood sugars. But now with the advent of insulins that prolong the duration of action, you're really able to decrease that injection burden for the patients. So regular insulin, a mealtime insulin, has an onset of action between 30 to 60 minutes, and that provides a little more flexibility for patients. So prior to meal times, patients can take the injection, and then they have a little bit of time before the blood sugar starts dropping. It peaks within 2 to 3 hours, but then has a long duration of action. So it has a fairly significantly prolonged duration of action when you compare it with a rapid-acting insulin analog of 4 to 6 hours, and we'll talk about the consequences of that. So the dissociation from the hexamer to the monomer leads to a delay in absorption. And it has that delayed onset and peak, so patients can administer it 30 minutes prior to their meal. That long duration of action is what leads to an increased risk of hypoglycemia because it does provide some basal coverage because after the meal, it's not completely renally cleared. It does stick around for a little bit. So then when given with a long-acting insulin like NPH, that predisposes patients to insulin stacking, which increases their risk of hypoglycemia. It's inexpensive, and it can also be administered IV, which oftentimes is what you're going to see in the inpatient setting when they're using a sliding scale. And that half-life is going to be anywhere from 9 to 17 minutes. In contrast, these rapid-acting insulins such as Lispro, Aspart, Glulisine, and most recently Technosphere, these have a much faster onset of action and they don't stick around as long. So their duration of action is going to be 3 hours to 5 hours max. So then they're going to be cleared much quicker and then won't predispose patients to hypoglycemia to the same degree. However, because they work very, very potently, they're very efficacious at bringing blood sugar down, if patients don't eat within 15 minutes to 30 minutes of taking the injection, their blood sugar will start dropping very quickly. These more closely mimic natural physiological secretions, so when compared with NPH, oftentimes A1C reductions can be superior. Patients should be counseled to administer 15 minutes before a meal, at the start of a meal, or in patients that have hypoglycemia unawareness, elderly patients, or children who may have, whose insulin administration and the amount of insulin may not match what they eat. They can actually eat, and then based on the amount that they took in, then provide their injection. These are very expensive, but they are very efficacious. And then I just wanted to touch briefly on Technosphere insulin, which comes in the brand name Afrezza. It's an inhalation formulation of insulin for patients who may not want to take more frequent injections, but it is on the marketplace right now, but I don't see it having a strong role simply because the kinetics, when compared to a subcutaneous insulin injection, are just not as convincing and strong. So here you have your rapid-acting insulin analog. So for a type 1 patient, they're typically going to take the rapid-acting insulin 3 times a day, breakfast, lunch, and dinner. Or they can take their short-acting insulin 3 times a day, breakfast, lunch, and dinner. And here you could see kind of the differences between rapid and short. So rapid is definitely more potent. So the same degree and the same number of units of insulin is going to drop your blood sugar a little more with rapid. However, it's cleared much quicker in the body. So then you don't predispose patients to that insulin stacking and basically having them have their insulin stick around when they're taking their next injection, which is what's going to predispose them to an increased risk of hypoglycemia. So here's just a pharmacokinetic summary of the different types of subcutaneous insulin formulations. So you have your rapid-acting insulin analogs, which are going to most closely mimic your physiological insulin secretion. You have your regular insulin, which is your short-acting agent that provides your prandial coverage, but sticks around a little bit longer than your rapid-acting insulin and has a little bit delayed of an onset when compared with your analog formulations. Your NPH, which is going to be classified as an intermediate insulin, but does provide basal coverage. But remember that in contrast to glargine and detamere, which also provide your basal coverage, NPH actually has a peak. So that peak is what's going to predispose patients at 4 to 8 hours after injection to hypoglycemia. So that's why it's very important that if they take their NPH at breakfast and dinner, that you tell them to have their lunch, not skip their meal, because that peak is going to come into play, and then prior to bedtime to take a small snack in to minimize that risk of them dropping low. And then finally you have your glargine and detamere, which are going to be your long-acting peakless insulins that are going to provide that basal background insulin coverage without really predisposing patients to hypoglycemia because, again, they don't have that peak. So with that, we'll close out that, and then the next slide set, we'll talk about the normal patterns of insulin secretion and how do we design an insulin treatment regimen.